Good morning, friends. Welcome to a new subject. In 1969, a male patient who was about 45 years of age was admitted in the Department of Medicine, All India Institute of Medical Sciences. The patient was running low-grade fever and was a known case of chronic pyelonephritis. Naturally, the attention was focused on the kidney as the cause of fever. His urine was sent repeatedly for microscopic examination as well as culture and sensitivity, but it turned out to be negative. His renal scan was done, which was normal, and his renogram was done, which was prevalent investigation at that time. That also turned out to be normal. Let me tell you a word about renogram. In renogram, a radioactive dye is injected in the vein of the patient, and patient is made to sit near a radioactive detection counter, and the radioactivity is recorded. It has three phases. First phase is called the vascular phase. There is an abrupt rise in the radioactivity. The next phase is the secretory phase, where renal parenchyma secretes the dye into the urine. And third phase is the phase of excretion, where the dye is excreted in urine. Now, simple to understand, if there is an obstruction in the urinary tract, like for example stone or something else like this, which is obstructing the flow of urine, then the third phase becomes prolonged. You can see that in the graph. But if there is a renal artery stenosis, narrowing of the renal artery, less blood is going to the kidneys, and therefore the first phase becomes less marked. If there is disease of the renal parenchyma, then the middle phase is affected. Well, friends, with these normal investigations, we thought of doing something more to find out the cause of the fever. We did the X-ray test, thinking that it may be tuberculosis, but it did not reward us. The X-ray test was negative. We did a Mantoux test to detect tuberculosis infection. Mantoux test is when we inject 0.1 ml of solution which contains 5 tuberculin units, and that is injected into the forearm of the patient. I'll show in the diagram how it is injected in the forearm and where it is injected. Now see this, I bring it close to the screen so that you can see. It is the front side of the arm, and you can see the syringe and needle. Needle has pierced the skin, and when we inject the dye, the skin becomes raised, like it has happened here. You can see it here, very close by. This is the area which has become raised above the level. Now, what then we do? We mark it by a circle. And then we read it after 48 to 72 hours. And what we find? We find it like this. This is all the area which has reacted to the tuberculin thing. See this red area, it is slightly raised also. It is red, it is firm. This is called induration. This induration in this case is 20 millimeter. Anything above 10 millimeter is considered as positive. But in our case, this test was negative. So this also did not benefit us. Then we thought of going to some other thing. But before I go to other things, I want to tell you about chronic pyelonephritis and the kidneys. This is a diagram to show you the kidney. See, it is quite close. It is excretory system. You see, these are the bean-shaped organs. Here, where my pencil is, it is bean-shaped organ, both sides, and from the organ, this is going down. This is the ureter. Look at this. This is the ureter, both sides. You can see this ureter, and this ureter is going here, here. In another structure, this is called urinary bladder. And from the urinary bladder, it goes out. See the another diagram of the kidney. See this diagram of the kidney. This is the pelvis of the kidney. This all is the pelvis of the kidney, and the rest is the parenchyma of the kidney. So pyelonephritis means the infection and inflammation of this area as well as this area. This all is inflamed in chronic pyelonephritis, and the urine is formed in microdrops. It comes from these spikes, these various spikes. It is coming from there. It is collecting in this pelvis. From the pelvis it goes into the ureter, and from the ureter it goes into the bladder. Now, when we were not benefited by all these things, we thought of other things. We took an X-ray test which turned out to be negative. Tuberculin test turned out to be negative. So tuberculosis we ruled out practically. We thought of some other diseases. Typhoid is very common in our country. So we did this Vidal test that turned out to be negative repeatedly. So having ruled out the tuberculosis and typhoid, then we switched on to some rare illnesses. We did anti-nuclear factor for the collagen diseases, that also turned out to be negative. Then we thought of why not to think a simple thing which happens in our country quite commonly. We request the pathologist to please spend a little more time on the slide peripheral smear to detect if there is a malaria parasite. This is not surprising because there is so much rush of peripheral smears examination that one cannot spend too much time on one slide. And you are seeing this slide under IL immersion, and how many fields you can see. This pathologist was a dedicated one. He spent time on the slide, and ultimately we were rewarded. He said that it is a malaria parasite positive. We gave the conventional anti-malaria treatment in the form of chloroquine, and the patient started responding. Patient became afebrile, and we discharged the patient. In follow-up, we found that patient has normal, his fever was normal. So we were satisfied with this thing, but I want to tell you here something more about the malaria. Malarial parasite, after entering the body, first enters the liver, and then when it comes out of the liver, it attacks the red blood cells. You will see here, first thing is that in the red blood cells, concentrate on this. These are the big cells with big nucleus inside. Some are even bifid nuclei. They are all white blood cells. We call them leukocytes. They are white blood cells. The other, if you see the other diagrams, they are just showing you the malarial parasite in different stages. This is this stage is called Scheizant stage. Here the malarial parasite is big in size comparatively. I am trying to make it as close to the screen as possible. See, it is close to, it is called Scheizant stage. And what is this? This is a, see, close, very close. Let us come very close to it, and you can see here. You see, this is a dot here, and see this is a thin line around. It is forming a ring, like a stone is in the ring. It is forming the same way. It is forming same way here, ring, here also ring. This is called ring stage or signet ring stage. This is signet ring stage. This comes after the schizont. A ring is formed, and then it divides into many ones. These are called trophozoites. This is the trophozoite stage of the malarial parasite, that is Plasmodium. It is liberated when it bursts. It is liberated in the blood, and this, when mosquito, Anopheles female mosquito, draws blood, it carries some of these trophozoites in the form of sporozoites in its salivary glands, and then passes it to the other human beings. So friends, that is how the malarial cycle in short goes. You must what we learn from it, that we must spend time for investigation. It should not be just eyewash. And I will tell you another case where it was not malaria, still the pathologist reported it to be malaria. Thank you very much. But friends, do like, comment and subscribe the channel, and if you want to get further information on the upcoming videos, please press the bell button. I may also remove a misunderstanding that many friends whom I sent the link, they make a sign there, a sticker there, that they like it. That does not serve the purpose. The purpose of sending you link is that you click the link, the video will open, you watch the video, you like it, you comment on it, you give suggestions for the future videos which may be helping others also. So friends, meet you next time with a new case. Thank you very much.